By minimizing skin flares and minimizing itch, you actually get higher quality of life outcomes.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, I've just been itching about something that I'd like to talk about.
Well, I hope you want to talk about atopic dermatitis or eczema, because that's what I want to talk about. Over the last decade, we had an explosion of information really talking about the skin barrier, then moving to immunologic mechanisms. And we know so much about this, but then we have so many therapies and how to choose and how to think about it. And we really need someone who can really help us to take us from the micro to the macro to really understand how the structure of the skin really impacts its function, and then the therapeutics that we can select. So much information, so many clues that are out there. We need someone to help us put it together into a coherent picture. Do you have someone who can help?
Yeah, so many experts out there, but we found the one that's also a structural biologist. And before I get into this, I just want to say that this podcast is sponsored by Leo. And we have as our special guest, Dr. Christopher Bunick. He is an Associate Professor of Dermatology at the Yale School of Medicine in the Department of Dermatology there. He is both a clinician and a researcher, so we're quite lucky, and he has pioneered a whole new focus in dermatology, looking at fundamental biochemistry, but also bringing in the structural biology knowledge and research too. So he's able to connect in the atomic resolution mechanisms of action to the therapies that we use in the clinic on a daily basis, and really look at, their performance and their safety. Chris, welcome to the podcast.
Well, thank you guys for having me. I love atopic dermatitis. I love talking about red, itchy skin and how to make it better. It really changes people's lives, and I'm ready to dive in with you from the clinical point of view and as deep as the science as you want to get into.
That's fantastic. And perhaps we can get started with talking about your work in the lab, because you are not a common dermatologist. We have plenty of dermatologists who have a lab. You are one of those folks who have a lab, and your lab focuses on structural biology, right? So can you give us a sense of what kind of size molecules we're looking at? Are you at the atomic level? Are you at a protein level? Where do you kind of zoom in?
Well, the answer is it spans a little bit. We've worked with small peptides as short as 40 amino acids. We've also worked with huge mega Dalton complexes such as the ribosome. We've used cryo-electron microscopy to look at the ribosome, particularly the Cutibacterium acnes ribosome, bound to specific antibiotics that we use in dermatology, and those are massive complexes, right? They're machines producing all the proteins that our body needs, translating messenger RNA into proteins. We span the gamut. Obviously, the larger complexes are more amenable to cryo-electron microscopy, but the smaller proteins and protein ligand complexes are very amenable to crystallography. And we use both techniques in our lab and have a lot of fun doing it. It's nice. I will say it's nice being the only one that's running a primary structural biology research in dermatology. It gives a lot of unique angles. Everything you produce is unique. However, early in my career, it was hard to convince dermatology that what I do is important. And I think that one of the things that's really transformed how dermatology views molecular differentiation has been applying the structural biology we do to understanding drug mechanisms of action, because then it becomes translationally relevant to the everyday clinicians taking care of patients to understand how their drugs are working at a deep molecular level.
I think this is really cool stuff, especially because at the end of the day, I mean, we are getting more and more sophisticated with the approach to drug development. So I thought, let's talk a bit about atopic derm. And, can you give us a little background on just some of the pathophysiology that we've learned along the way with atopic dermatitis, and how are we getting more and more specific with really going after those cytokines that are making a difference?
I think this is an incredibly important perspective to have. So when I was starting residency in 2009, finishing in 2012, that 3 year span, there was still a prominent discussion in dermatology around treating atopic dermatitis, that it was a disease driven by barrier dysfunction, particularly filaggrin dysfunction or mutation. And the truth is that this barrier centric focus to atopic dermatitis, well, there were a few moisturizers that came out that tried to use filaggrin replenishment, but in reality, moderate to severe atopic dermatitis does not seem, or at least wasn't solved by treating with any type of filaggrin therapeutic. And this is where the true understanding of atopic dermatitis, much like psoriasis, shifted from a barrier centric focus to a inflammatory and immune centric focus. And then the emergence of the biologics targeting some of these cytokines that are playing a role in the Th2 or type 2 inflammation that drives atopic dermatitis. Those therapies tended to be miraculous. And what's really amazing about understanding the pathophysiology of atopic dermatitis is we now know that there are 6 major cytokines that seem to play a role in the disease: IL-4, IL-13, there's IL-31, and then there's TSLP, and then you also have IL-22, which tends to be more involved in epidermal thickening, maybe some more chronic disease, as well as interferon gamma, more involved in chronic disease. What's interesting about IL-22 is it seems to also play a role in head and neck atopic dermatitis, particularly some of the paradoxical head and neck dermatitis that worsens for some patients that are on dupilumab. So these 6 cytokines really now are the focus of not only current treatments, but innovative treatments that are coming in atopic dermatitis. So we've sort of seen a shift from the barrier world to the cytokine centric world. But I want to just give a teaser that I don't know that it's going to stay that way, meaning that there are now some companies out there that are combining immune targeted, like cytokine targeted therapies, with coming back to understanding the barrier dysregulation in atopic dermatitis. And what you're going to see, and what I'm really excited about, are some of the therapies that are now targeting kallikreins, these proteases that do a lot of tissue damage and perpetuate that barrier dysfunction inflammatory immune cycle. And I think that with the emergence of some therapies that target both kallikreins and the IL-13 and other cytokines, I think that's going to be very exciting to see how bringing barrier dysfunction and correction of that barrier dysfunction into bispecific therapeutics is going to be very interesting in atopic dermatitis.
That was a great overview, Chris. Thank you very much. Perhaps you can now tell us how your lab and your work and some of the work of others that you've seen in your neck of the woods really impacts this and maybe opens the door for new therapeutics. Because you mentioned, I think we are all aware of dupilumab and how it changed how we practice dermatology when it comes to atopic dermatitis. But maybe you can help us think through some of the other cytokines and really why do we need more medication? We all thought, all right, we have dupilumab. It seems to be working well. Why do we need more?
Well, I think the simple answer to why we need more is that not every patient responds to dupilumab. Patients that do respond to dupilumab do not always maintain response over time. We know that atopic dermatitis is a chronic disease, and we need therapies that have durability over time, and that is for years, if not decades. And so there's always a need for more therapies. And one of the, I guess, a scientific way to describe it is we now know that atopic dermatitis patients can be clustered into what are called endotypes. If clinicians out there listening to this haven't heard of the word endotype, it's basically subgroups of atopic dermatitis patients that fit together. So, for example, some may have higher IL-13 driven atopic dermatitis disease, whereas others may have a higher component of IL-22 or interferon gamma or IL-31 driven disease. Not everyone's atopic dermatitis is exactly the same. It's sort of like hair color, hair texture, eye color. We're all different as humans, and actually the subgroups of atopic dermatitis are different too, and we call that the endotypes. And to treat these different subgroups or endotypes within atopic dermatitis, not one therapy necessarily hits them all equally well. And not only in terms of the depth of response, but the durability of response. And this is incredibly important because this is why you're seeing the need for therapies beyond dupilumab, right? We have tralokinumab, we have lebrikizumab, we have now nemolizumab as your 4 biologics, and then we have the 2 JAK inhibitors, upadacitinib, abrocitinib, that are approved. And I think that the other underlying principle that's driving the need for more therapeutics, at least from the biologic standpoint, is that one of the benefits of targeting or treating atopic dermatitis with JAK inhibitors is that they hit all 6 of those cytokines that we've been talking about. Whereas biologics to date are monospecific, meaning they have one target. Dupilumab targets IL-4 receptor alpha, happens to hit or decrease signaling from 2 cytokines, IL-4, IL-13. So you're hitting 1 or 2 cytokines through monospecific targeted biologics. And what we're seeing is a response from industry saying, wait a second, we realize that there are more cytokines important in atopic dermatitis patients. Therefore, let's create bi and tri-specific therapeutics. And if you thought that atopic dermatitis was complex, now with 6 therapies, there's at least a dozen therapies in development now that are biologics that target 2 or more different cytokines. This is how aggressive the innovation is in atopic dermatitis at the moment. There are so many therapies coming down the pipeline. However, what I'd like to emphasize is that all those therapies are somehow built around the 4 main biologics we have now, right? Dupilumab, tralokinumab, lebrikizumab, and nemolizumab. Those targets that they're hitting, the cytokines, they are the foundation for all of these bi and tri-specifics. So if you don't understand the therapies that we're currently using now, it's going to be harder to understand why these different combinations of targets are emerging in the multi-specific biologic space in the investigational world.
Chris, can you talk a little bit about, these cytokines as an individual? I mean, there are some that obviously, like you mentioned, dupilumab hitting, even though it targets one cytokine pathway, it ends up really affecting 2. What has been this growth in going after, like, what was so special about IL-13 specifically? I mean, why was there such a focus on that? I know now we've moved towards bispecifics and whatnot. Nevertheless, I mean, there's still this focus on IL-13, and what's the reason for that, or what's the rationale?
Well, I think that the underlying rationale for targeting IL-13 is it does seem, even though it may not be the only cytokine, it does seem to be one of the most prominent cytokines driving atopic dermatitis. And the evidence clinically in that is that you have drugs like tralokinumab and lebrikizumab that are IL-13 monospecific. And for moderate to severe atopic dermatitis patients, these biologics can have incredible response for many of the patients that they treat. The thing about IL-13 and the reason that IL-13 has emerged as such a strong candidate for targeting, and I'll add in the caveat that we know IL-13 is so important for targeting because the majority of the bi and tri-specifics in development incorporate IL-13 targeting in some way. And that is that when you look at expression, whether it's at the mRNA level or the protein level in the peripheral skin and keratinocytes, what you see is that IL-13 is the predominant transcript and protein in the peripheral skin there, and that is where where the atopic dermatitis is happening. When you compare that to IL-4 messenger RNA or protein levels, those levels are much smaller, almost sometimes undetectable. So there seems to be a huge disparity when you look at the when you do your omics analysis, whether it's transcriptomics, proteomics, there seems to be a big difference in the amount of IL-13 compared to IL-4 in the keratinocytes in the peripheral skin, and that is where I think the strategy has emerged to really target IL-13 regarding IL-4. But this is a difference in terms of underlying asthma, where there seems to be a difference between asthma and atopic dermatitis, where the IL-13 monospecific therapies have had a little bit less performance in treating asthma than dupilumab. Some people say that could be dose dependent, and other trials might show different. But at least as things stand now in the trials, that hitting IL-4 has been a highly successful strategy in asthma. So there's some differences, I think, between the lung and the skin in terms of the role of IL-4. But IL-13, for a large part, plays a huge role in driving the inflammation from the keratinocytes in atopic dermatitis.
This is so cool. I mean, we get to talk about biology, we get to talk about biochemistry, but you're a clinician as well. And so I've got some clinical questions for you. So this is really interesting how our therapeutics has just evolved. But I want to take maybe a broader view on when you're seeing a patient in the clinic. I mean, many of them have struggled for years, and many, and I don't know if this is a unique thing that you've also noticed, same to you, Hadar, but my atopic derm patients are almost learned to kind of be okay with mediocre therapies. And then when they get onto something that can really help clear them, they're like, I didn't know I could get this clear. So can you talk a little bit about what is the journey of a patient when they get to you? Do they go on to systemics right away, or what are some of the struggles that they faced, and how do you approach that?
I think you're sort of hitting the nail on the head there. Really, what you're describing a few different key concepts. One is one is actually just educating patients about their options, and two is therapeutic inertia. So let's start with therapeutic inertia. Therapeutic inertia is the concept that clinicians tend to keep patients on certain therapies for whatever bias they have, even if the patient isn't responding uh, to the degree they need to respond. And we see that there's real world data from the Target Derm Registry showing that a group of atopic dermatitis patients that were almost 70 to 80% of these patients were not hitting optimal treatment targets, whether it's EZ90 response, IgA01 response, or itch 0 or 1. So 80 to 90, 80, roughly 80% of these patients are not hitting these optimal treatment targets. And over the course of a year in this Target Derm Registry, 80% of those patients were on dupilumab. And because dupilumab was the first biologic that came out in dermatology and for treatment of atopic dermatitis in dermatology, what we've seen is that there is this tendency for dermatologists to put patients on dupilumab and just leave them on it and not actually reassess, is this patient hitting a certain treatment target? And we hear a lot now about treat to target goals emerging in the treatment of many diseases, including atopic dermatitis. And for those that haven't heard about it, there are new guidelines. There's the AHEAD recommendation. So AHEAD stands for Aiming High in Eczema and Atopic Dermatitis. And they have come out and said, we as the clinician need to strive for optimal treatment targets in our atopic dermatitis patients within 3 to 6 months. That means, in simple terms, and the patient's achieving both skin and itch clearance, not just skin, and at high levels. So IgA01 or EZ90 plus itch 0 or 1 on that 0 to 10 numerical rating scale. And this is a fundamental paradigm shift in how we treat atopic dermatitis, because what I can say is, 8 years ago, when a moderate to severe atopic dermatitis patient came into my clinic, if I were to put that patient on methotrexate, methotrexate, just to pick an example. And if that patient got better, I would pat myself on the back saying, wow, I'm a really good doctor. I helped this patient get marginally better in their severe atopic dermatitis with methotrexate. I'm really smart.
So
But that's
crazy.
it's crazy, isn't it? But that's not where we are today, right? It's not okay just to have mediocre response. It's not okay just to have skin response. You have to have itch. You can have an atopic dermatitis patient in the clinic that has completely clear skin, but may have a 9 out of 10 itch, right? Kind of your average daily itch of 9 out of 10, and that patient is miserable even though their skin may look clear. And that is what the AHEAD recommendations seek to educate about and to inform about, is that atopic dermatitis patients, to improve their entire quality of life, you have to target both the skin and the itch, and then downstream, and there's published data that shows this, that by minimizing skin flares and minimizing itch, you actually get higher quality of life outcomes. And this could be reflected in more daily activities, such as being able to swim in a pool, or it could be reflected in greater work compliance, or it could be reflected in better sleep. There's a number of quality of life outcomes. But to tie all this together, the point is that there's new benchmarks led by this AHEAD recommendations to hit itch, to achieve optimal skin and itch clearance simultaneously. And this is elevating the standard of care of treatment of atopic dermatitis. So it's no longer okay to leave patients on mediocre therapy with mediocre response. And this is where I think that we as the clinicians, and I know I have to remind myself about this, is you have to step back and say, okay, what's the totality of the quality of life picture of this patient? I think their skin's a little better. Are they itchy? Are they not? Are they sleeping well? Are they functioning well? Is this therapy truly transforming their lives and getting them to not just an optimal treatment target, but this concept of minimal disease activity? And if the answer is yes, keep them on the therapy. But if the answer is no, we have to understand all the therapies at our disposal. And right now we have 6 FDA approved advanced systemic therapies. And I'll just throw out a caveat here that oral corticosteroids are not the answer. And in fact, I'll put a plug in. There will be a consensus. A group of AD experts recently got together, and there are going to be some consensus guidelines from this expert panel coming on the use of systemic corticosteroids in atopic dermatitis. And we already know that the American Academy of Dermatology's AD guidelines that were recently updated in 2024 conditionally recommend against the use of systemic corticosteroids for the treatment of atopic dermatitis. And I stand behind that recommendation fully.
Yes, wow, that was a really, really good and powerful message, I think, to all clinicians, Chris. Thank you very much. I think that you're absolutely right that we shouldn't settle. I'm reminded of a patient that I've seen who was 70 years old. This was a few years back. Only dupilumab was on the market. And when she first got dupilumab, I asked her, how have your life changed? And she said, after 2 or 3 weeks on the medication, I realized for the first time, this is a 70-year-old woman who's saying, I realized for the first time what people meant when they said I had a good night's sleep. Right? So that is, if that doesn't give you goosebumps or make you want to cry, I don't know what will, but that is the impact of the disease. And the flip side, so you made a compelling argument about the clinician. Sometimes the challenge with these systemic therapies, and especially when we're treating kids, is looking and flipping this over and telling this to the patient, because there is some resistant or hesitance or natural questions that will come up with treating systemic therapy for something that, and I'm using my air quotes here, just affecting the skin for a little rash. Why do we need that? And I was wondering, how do you then take all this and maybe can help with a tip or two to our listeners to understand, how do you you explain all this complexity to the parent or the adult patient sitting in front of you?
I think that when it comes to pediatric atopic dermatitis, there's really now a compelling and very simple message. We just we now know that there's significant improvement in uh, children that have moderate to severe AD. That there's significant improvement in their bone density, bone mineralization, and their growth curve, right? You know, height, weight, BMI. There's significant advantages to treating children that have atopic dermatitis. And this is really profound when you step back and look at the picture. So, whereas we have six FDA approved therapies, advanced systemic therapies for adult atopic dermatitis, in the pediatric realm, we currently only have one, and that is dupilumab. And that ranges from 6 months to 11 years in that pediatric group. And some of their data on pediatric health is incredible because we think about maybe more in psoriasis than AD, we think about the systemic inflammation causing harm to other organs, whether it be the cardiovascular system or whatnot. And in atopic dermatitis in adults, we're now learning that maybe there are some increased risks of cardiovascular disease, clotting, other consequences of the systemic inflammation if it's not treated. But in kids, this is a revelation because I don't think that we've really talked about it before, that the systemic inflammation caused by pediatric moderate to severe atopic dermatitis is real, and it has an impact on their height, their weight, their growth, their development, their bone mineralization. And intervening early in these children with dupilumab is actually changing their lives in ways that we not just that go not to be cliche, but go beyond skin deep. And this is the conversation that I think clinicians should be having with with I guess if the children are old enough to understand, but really the parents of children with atopic dermatitis, that intervening early is actually better for the health of your child because the systemic inflammation has
Right.
multi-organ consequences. And that is a truly profound shift in thinking. And it's something that topical therapy is not going to fix. And I do think that other therapies that are being studied in pediatric AD, including tralokinumab and lebrikizumab, are likely to show the same benefit as what we're going to learn once those clinical trials are completed.
Well, perhaps one way, instead of saying treat the target, which we say to clinicians, I think for parents and patients, one of the things I'm trying to incorporate into my daily spiel about various treatments is I don't want to treat to thrive. I'm sorry, I don't want to treat to survive. I want to treat to thrive. I want your kid to thrive. I want the child to really, really do well. A lot of this probably has to also do with sleep. And a concept that I think I may have shared on this program before is the idea of informed consent. We're really big on that. I don't think that the patients can really give informed consent. And let me explain what I mean. It sounds a little paternalistic, but follow me with that thought for a second, Chris, because you have a parent who saw their child who's now 8 for the last 6 years dealing with atopic dermatitis. They don't know a different reality. All they know is sleepless nights, itchy skin, periodic infections, right? And the child doesn't want to go out and socialize, and all this downstream effect. And then they don't know anything else. And then you give them a medication that reduces the itch, clears the skin. The child starts sleeping better in school, better. All of a sudden, 6 months later, they cannot recognize your child. They cannot recognize their child. And what I've started saying to patients, why don't you try it for 6 months and see how you're doing? And then come back and tell me if you really are interested in not taking this medication. Because I think we forget how many adjustments we make for ourselves as patients or for our children who are their patients in order to just accommodate for one chronic disease. So I think that those are a few tips to incorporate into that. Chris, maybe for the end of the conversation, I wanted to ask you, because you were mentioning the different mechanisms and different options that are available and different maybe phenotypes that are presenting in atopic dermatitis, at least for the adults where we have such a wide selection. Are there any phenotypic clues that clinicians can lean on to maybe choose one medication over the other? I don't know that there's great data to support this, but at least how do you think about it in your clinic? And I'm going to assume right now that the insurances are perfect and everything else is perfect.
Yeah, everybody will come back and say that the insurances are a major barrier. But assuming that they're all perfect, I think that first and foremost, we have 6 amazing therapies. These 6 advanced systemic therapies, 4 biologics, 2 JAK inhibitors, are better than doing nothing. Any one of them is better than doing nothing for a moderate to severe atopic dermatitis patient. As a whole, we do have head-to-head trials between both oral JAK inhibitors and dupilumab, and I think that we are in a state of understanding that the JAK inhibitors as a whole have a quicker onset of action and deeper response, both from a skin and itch standpoint. But again, not everyone is going to start directly with a JAK inhibitor, although, at least in my personal opinion, they can be first line agents and should be first line agents. That's a topic for a different discussion. In terms of the biologic therapies, I do think that there are some clues clinically that can help you pick. So, first of all, right now, if you had a patient that had concomitant asthma and atopic dermatitis, dupilumab is likely going to be your pick because it's approved in both diseases. In the case of head and neck atopic dermatitis, well, with head and neck atopic dermatitis largely driven, or at least seems to be driven in part by a skewing towards IL-22, and we know that dupilumab can have this paradoxical head and neck dermatitis. If a patient has very strong head and neck atopic dermatitis, I think that using tralokinumab or lebrikizumab from a biologic perspective makes a lot of sense. I think nemolizumab's data on head and neck atopic dermatitis, we just haven't seen that yet. And both JAK inhibitors, upadacitinib and abrocitinib, also would be very good for head and neck atopic dermatitis. But I think that's one distinction that you would make. In terms of when people think about adverse events, what we do know now is that oral JAK inhibitors have a lot of data showing that they are potentially cardioprotective, not harmful. So I do think that the safety concerns that people have, maybe distinguishing biologics from JAK inhibitors, that just doesn't seem to be playing out now that we have more and more up to 6 years safety data now for upadacitinib, and I think 4 or 5 for abrocitinib. We're just not seeing the initial concerns play out. So I think that clinicians have truly a wide range of options to choose from, and the data speaks for itself that these options are better than doing nothing. And if I think that where that comes into play is there's recent data from a year ago that I was co-author on showing that 1 in 5 atopic dermatitis patients is still getting systemic corticosteroids. And of those patients, almost a third of them are long-term steroids, which is greater than 90 days worth of corticosteroids. So think about that. There are dermatologists still prescribing long-term, greater than 90 days systemic corticosteroids for atopic dermatitis patients. And I don't think that that's standard of care. And those are areas where we can improve how we take care of patients.
Chris, thank you
Wow.
for taking us on this journey. That was awesome. I mean, we got to go everything from micro all the way to macro. I want to thank you for your time. And then, Hadar, I think you were about to say something too.
Yeah, no, I mean, I'm just really, really impressed, Chris. In just about 30 minutes or so, we were able to package a lot of great and new information. I think you took us talking about the different tools in our toolbox and gave us hope for the future that we're going to get even more sophisticated how to talk to patients about this, how to talk to our other clinicians, how to really think about this, and then maybe finding some clues in our patients. So thank you so much. For those of you readers, for those of you listeners who also want to be readers, look for Chris's paper recently published in the Journal of Investigative Dermatology, reviewing all these mechanisms, really picking and teasing them apart. One of his many publications to celebrate. So thank you, Chris, for joining us.
No, it's been a real pleasure, and one thing I'll add in the closing seconds here is just we didn't talk about adverse events, and we recently published a case series showing that when patients are on dupilumab and they develop joint pains, This is thought to be due to a Th17 skewing, and there's data showing that switching from dupilumab to a biologic like tralokinumab can actually eliminate the joint pains that these patients are experiencing. And so I do think that that's one other area where selecting therapy is very important, and paying attention and asking patients that are on dupilumab about arthralgia is very important, because it's been shown that these patients absolutely develop arthralgia. In fact, it's in the package label that we as clinicians need to ask our patients about arthralgias and psoriasis-like rashes in dupilumab patients. And I think that this is where one area where tralokinumab really excels is switching patients that are developing these arthralgias. They seem to do very well on tralokinumab.
Thanks again, Chris. Really appreciate your time. And I just want to remind everybody that this podcast is sponsored by Leo, and we appreciate our ability to work with industry to get out high quality education, and we look forward to doing more.
Thank you for tuning in to the LearnSkin podcast. We hope you enjoyed today's episode and found valuable insights to take away with you.
And before you go, we'd love to ask for your support in helping us reach even more listeners just like you. Leaving a review on your favorite podcast platform not only helps us improve, but it also boosts our visibility and helps others discover our show.
So, if you found this episode helpful, inspiring, or thought-provoking, please take a moment to leave a review and share your thoughts. Your feedback means the world to us, and it truly helps us grow.
Thank you again for being a part of this journey with us. And until next time, stay curious.